Good evening, everyone, and a warm welcome to today's webinar. I am Arpita, the moderator for today's session from the IGCP group. It's an absolute pleasure to have all of you join us for this insightful session on placenta accreta spectrum disorders, diagnosis, and management. As we all know, PAS disorders are among the most challenging obstetric conditions requiring timely diagnosis, multidisciplinary coordination, and advanced management strategies to ensure the best possible outcomes for baby and the mother. And to guide us through this important discussion, we are honored to have with us Dr. Jyoti Malik, ma'am, a distinguished expert in the field. She holds an MBBS, DGO, DNB, MNA, and FICS and currently serves as a medical superintendent at JJ Institute of Medical Sciences. With her extensive experience in obstetrics and gynecology, she has been at the forefront of maternal health, advocating for evidence based approaches in high risk pregnancies. So, with this very brief introduction of yours, ma'am, now I would request you to please start with the topic for today. Over to you,
Yeah,
ma'am.
right. Thank you so much. Thank you, Arpita, and thank you, the IJCP group, who I have been on this platform multiple number of times. And every time they give me a new topic related to infertility, obs, gynae, and I really enjoy this platform because this is something where we share knowledge with each other, and sharing means you learn more. So today I would be talking on the placenta accreta spectrum disorders, the diagnosis and the management. Why we are talking this? Because the number of cesareans is increasing day by day, and because of that, the increase in cesareans, the this spectrum of placenta accreta is increasing. Now, what is placenta accreta? Placenta accreta is something which is a spectrum of where abnormal placental adherence is there. It can range from anywhere from a microscopic finding or a subclinical adherent placenta to the myometrium within the basal plate to the extreme dramatic presentation of placenta percreta, where it goes through and through the uterus, through the myometrium, into the serosa and the peritoneal cavity. So previously it was a histopathological term as far back as 1937 it was devised, and it is a spectrum disorder where it ranges from abnormally adherent to deeply invasive placental tissue. So, depending on the depth of this placenta, how much it is going into the myometrium. So, this is the normal way the placenta should get attached. So, we have this endometrium here or a basalis plate here, where this normally the placenta gets adherent and it gets removed very easily. But if it is adherent to the myometrium, if it is attached but does not invade the myometrium, it is called accreta. If it invades the myometrium, it is increta. And if it goes beyond or if it touches the serosa, it is percreta. So we have various, depending on the depth of the villus tissue invasion, we have these various categories. So it is the same thing when it is just there is absence of the intervening decidua, it is accreta, and if it is partly going there in the myometrium increta and going to the serosa or beyond is percreta. So accreta is nearly 75%, increta is nearly 20%, and this percreta is 5%. So thankfully, it is the percentage of percreta and increta is somewhere around total, let's say 20%. So depending on the amount of placental tissue involved, you and the depths of accreta, it could be total, it could be partial, or it could be focal. Now, the most favored hypothesis is that there is a defect of the endometrial myometrial interface, leading to failure of normal deciduralization in the area of the uterine scar, which allows abnormally deep placental anchoring villi and the trophoblast infiltration. So this leads to a lot of maternal morbidity and mortality, and sometimes it could be even life-threatening. Though it is by definition it is APH, but it is an important cause of PPH. And the most generally accepted approach to this PAS is the cesarean hysterectomy with the placenta, where we leave the placenta in situ after the delivery of the fetus, and we don't even make an attempt to remove it, because when we fiddle with the placenta, the moment we fiddle with it, the bleeding would start and it becomes difficult to control. So the optimal management, as Arpita told us also, that it has to be a very multidisciplinary approach where we involve a very specialized team, and it is done at a tertiary center. So even if sometimes if you without your if you do not know that this is a case of PAS, and if you open the abdomen, and if you find that you are not fully equipped to deal with it, you should close the abdomen and send the patient, rather than dealing with a case where you are unable to handle such a catastrophe. So you can diagnose it in early weeks, or it can be in the later weeks. You can diagnose even on the as soon as you open the abdomen, once you see the uterus. Sometimes you diagnose it once you have opened the uterus or delivered the baby and the placenta is not able to come, or sometimes you can even diagnose it much earlier, antenatally, whenever you do your scans. So what are the risk factors? So risk factor is any scar on the uterus, any direct surgical scar. Could be due to cesarean, could be due to termination of pregnancies, DNCs, myomectomies, endometrial resections. Or it could be non-surgical scars. It could be any IVF procedures. Normally we see that the placenta is not well, we can't remove it so easily in IVF cases. And it could be due if the patient has undergone any chemotherapy, radiotherapy, or there is endometritis, or there has been a previously intrauterine device, or manual removal of placenta has been done in the previous deliveries, or if there are any anomalies in the uterus, a biconate uterus, any fibroids or adenomyosis, etc. Now, the major risk factor for placenta accreta spectrum is that you should have if there is a history of accreta in a previous pregnancy, you should be ready for it, that you should be ready that you may encounter a PAS again. So a previous history, a previous cesarean delivery, a previous uterine surgery, and a repeated endometrial curettage, these are the cases where we normally should anticipate that the risk of placenta accreta syndrome spectrum may be there. Now, the risk rises as the number of prior cesarean section increases. So, women requesting elective cesarean, these days it has become quite common that the patient is asking us that they do not want a vaginal delivery, they want a cesarean. So, they should be informed that the number, as we get onto the number of cesareans increases, this PAS may increase, and the consequences for we have to explain to the patient in such scenarios. Now, does the number of previous cesareans affect the PAS? Definitely yes, because see, in this study that there was the rates of PS disorders that was correlated with the number of previous cesarean deliveries, and if you have one previous cesarean, the incidence of PAS is 0.03%. And if there is placenta previa, the rate of PAS is 11%. And if it is previous 3, 4, or 5 cesareans, the rate with the placenta previa is as high as 60 to 70%. And the incidence of PAS is around 2 to 6%, depending on the number of previous cesareans. So if it is more than 2 cesareans, the incidence of PAS definitely goes on increasing. So these are the recommendations on the based on the epidemiological data. The evaluation of the PAS showed that the recent increase is because of an increase in the cesarean deliveries over the last 2 decades. And a cesarean delivery scar increases the risk of previous and subsequent pregnancies as well. A myomectomy scar, minor surgical procedures like a uterine curettage, these all can lead to PAS disorders in the subsequent pregnancies. Now, women should be informed that their risk of PAS increases with each cesarean, and who request a pre-labor elective cesarean should be informed that their risk of developing is higher in an elective case than after any emergency cesarean deliveries. So these are the based on the epidemiology. So what is the gestation that we should start screening for PAS, and by which method? So women with a history of previous cesarean who have an anterior low-lying placenta or a placenta previa at a routine fetal anomaly scan should be specifically screened for placenta accreta spectrum. So this is the new 2018 guidelines are suggesting that at level 2 scan you should always look for placenta where it is located. And the best thing is the ultrasound imaging, because it is highly accurate when performed by a skilled operator with experience in diagnosing PAS. And whenever you have if you are doubtful, you should always refer these cases to a person who is specialized in such a imaging. Now, on ultrasound, what are the features is that in first trimester, you might see, if you see a gestation sac in the lower uterine segment, or if there are irregular vascular spaces in the placental bed, or a cesarean scar implantation. So these are all the features that you should always think that later on this patient might land up into placenta accreta spectrum. When ultrasound done in the second and third trimester, you see irregular shaped placental lacunae within the placenta, giving it a moth-eaten or a Swiss cheese appearance. Or there is a lack of hypoechoic placental myometrial differentiation. So retroplacentally, normally there's a clear space. So you should always see that behind the placenta there is a thin clear space. If it is there, you should feel happy that you are not dealing with a case of PAS. There could also be a thinning of the myometrium, retroplacental. If the myometrium is less than 1 mm, this we are dealing with a PAS. Or sometimes the placenta might protrude into the urinary bladder. So this is also another sign of placenta accreta. So these are the various images. So here, this is that hypoechoic space, and this is the placenta that as it's extruded, it appears to be bulging into the myometrium. Here again, it is going on towards the bladder, and you don't see any myometrium here between this placenta and the urinary bladder. Here again, there is a loss of retroplacental clear space. And here again, you see the it going into the bladder. So these are the various pictures that you see. You can see the venous, the placental lakes or the lacunae here. And the presence of increasing number of lacunae is the most predictive ultrasonographic sign of a placenta accreta. Now, on a color Doppler, you see turbulent flow in these lacunae, and you see vascular lakes with the turbulent flow, and with a peak as a systolic velocity of more than 15 centimeter per second. There is a hypervascularity of the serosa urinary bladder interface could be seen, or the blood vessels or the placental tissue bridging uterine placental margin, myometrial bladder interface, or crossing uterine serosa. On a 3D, again, you see hypervascularity, numerous vessels involving the whole uterine serosa, bladder junction, and inseparable cotyledons with intervillous circulations and chaotic branching and detour vessels. So the use of power Doppler, color Doppler, 3D ultrasound, you may do anything, but it does not improve your diagnostic sensitivity compared to what you get on a grayscale ultrasound. So even on a grayscale ultrasound, you can diagnose whatever you want. I mean, there is not much that power or color Doppler adds, but maybe you feel more confident once you see all those hypervascular spaces and the lacunar flow there. So the authors in the RCOG guideline 2011 said that 3D power Doppler is superior to a grayscale and a color Doppler. So on these we have already detailed you about the what we see on the grayscale and on the color Doppler. So how do you predict using a ultrasound scoring system based on the number of previous cesarean deliveries, the maximum dimensions of the lacunae, if it is less than 2 centimeter, more than 2 centimeter, the number of lacunae less than 2, more than 2, obliteration of the uteroplacental demarcation, the location of placenta, whether it is anterior or if it is a placenta previa, the Doppler assessment, the blood flow in the placental lacunae. So you have these scoring systems here based on the Doppler, based on the location of the placenta, the number of lacunae, the dimensions of the lacunae, and the cesarean deliveries. So if your score is between 0 to 5, there is low probability. If it is between 6 to 7, it is moderate probability, and 8 to 12, there is a high probability based on ultrasound about the morbidly adherent placenta. RCOG says that clinicians should be aware that TVS for diagnosis of previa or a low-lying placenta is superior to a trans-abdominal and transperineal approaches and is also safe. In women with persistently low-lying placenta or placenta previa at 32 weeks who remain asymptomatic, an additional TVS is recommended at 36 weeks to inform the discussion about the mode of delivery. And the cervical length measurement may help facilitate the management decisions in asymptomatic with placenta previa. A short cervix on TVS before 34 increases the risk of preterm emergency delivery and massive hemorrhage at cesarean section. So in the first trimester, a sac implanted in the lower segment or multiple hypoechoic spaces within the lacunae. So you should it should ring a bell when you are doing a first trimester scan that later on this patient may be in a case of placenta accreta spectrum. So this is 9 weeks gestation sac. It is more it is placed more low in the uterine cavity. So this is something, if we see such a picture, we should think of PAS. Again, a cesarean scar pregnancy. On a scan, if you see that, you should also suspect that this patient may later on land into PS. MRI should we do in cases of placenta accreta spectrum? What are the findings? You see a heterogeneous signal intensity, loss of myometrial trilaminate structure, uterine bulging, tenting of bladder, direct visualization of invasion of adjacent organs, and these are the findings. But MRI has comparable diagnostic accuracy to ultrasound. So overall, a grayscale ultrasound is good enough to diagnose placenta accreta. MRI is costlier, less widely available, requires expertise, and therefore you do it only in certain cases where you want to assess the depth of invasion and the lateral extension of the myometrial invasion, especially in cases of posterior placenta or in women with ultrasound signs suggesting the parametrial invasion. So these are the only cases where you should go in for an MRI to confirm your findings. Now, bladder filling should be done because ultrasound must always be done, should be carried out with a full bladder because it is vital to identify your lower uterine segment. Because here only at the lower uterine segment is the site where you are supposedly going to go in from that side, and if the placenta is there, then you have to avoid that. So, without a full bladder, these signs such as bladder wall interruption, the placental bulge, and the utrovesical hypervascularity cannot be appropriately assessed. So, you should have an adequate filling of the bladder so as to diagnose this entity. Now, pro pressure should not be too much, because if you put a lot of pro pressure on a transabdominal scan, it can lead on to loss of the clear zone behind the placenta. And there you can sort of then you can make a false diagnosis. So, therefore, you should not put extra pressure while doing the ultrasound, transabdominal ultrasound. So, COG guidelines say that the mid-pregnancy routine fetal anomaly scan should always include the placental localization site. The placenta previa term should be used when the placenta is directly lying over internal os. And if it is lying lower down, but it is less than 20 mm from internal os, you should use the term low-lying placenta rather than using the term placenta previa. So if the placenta is thought to be low-lying, that means less than 20 mm from internal os, or if it is a previa means covering the os, add the routine anomaly scan, do a follow-up ultrasound, including a TVS at 32 weeks of gestation to diagnose whether it is still persisting, whether it is a persistent low-lying placenta or a previa. Though ultrasound evaluation is important, but sometimes the absence of ultrasound does not mean you are not going to get a placenta accreta spectrum. So clinical risk factors also remain equally important. So if you have previous to cesarean patient, you should always keep in mind that you should be always ready. So if you have any clinical risk factors are there and the ultrasound doesn't show it, still you should be prepared. So the antenatal diagnosis of PAS is crucial in planning the management, because if you manage, you have planned your treatment part, your delivery part, your cesarean part, you can reduce maternal morbidity and mortality. And previous cesarean and the presence of anterior low-lying or placenta or a previa should alert the antenatal team care of the high risk of placenta accreta spectrum. So this is one case we will just take so that we can sort of correlate how we have to deal with our cases. So this was a 28-year-old unbooked G5P3L2A1, 37 weeks pregnancy, first vaginal delivery 10 years back. Then she had 2 cesareans 7 years back and 4 years back, and another abortion 1 year back. And she is unbooked, so she has only 1 or 2 visits antenatally in the periphery. And at 17 weeks, it was a anterolateral low-lying placenta. At 28 weeks, it was low-lying placenta. No ultrasound was done at 32, so we don't know what exactly is the situation now. And she has come to you at 37 weeks now. So now what to do? So you do an ultrasound, and on ultrasound you see that there is a central placenta previa with increased retroplacental vascularity with turbulent flow and linear vessels seen vertically oriented towards bladder. So you know that now you are dealing with a case of placenta accreta, with placenta previa because it is low lying. Now her vitals are okay just now. She is term size, cephalic, relaxed uterus. Fetal heart is 134. Her hemoglobin is 10.7, and the rest of the investigations are normal. So what should be your management plan? So in such cases where the patient has come to you and she has previous cesarean, she has a low-lying placenta, and so now what are the components of your team that should be there, and how you should tackle with such cases? So FIGO consensus guidelines, what do they say? That you should there should be a multidisciplinary team with a standard care plan which should be consistent, and you should have a proper checklist to guide your prenatal, intrapartum and postpartum care. the radiologic expertise for diagnosis, experienced obstetrician, maternal fetal medicine specialists with surgical expertise for complex surgeries like a gyneconco, a pelvic surgeon, a urogynec, expert anesthetist or a senior anesthetist, and neonatal intensive care unit, neonatologist, adult intensive care unit, intensivists. You should have the facility to deal with massive transfusion. You should have good access to the blood products, blood bank, massive transfusion protocol, transfusion medicine specialists, additional surgical expertise when required, like a urology, a vascular surgery, general surgeon, interventional radiologies, etc. So you should be prepared with such a case, and you should always be tackling this by the multidisciplinary team in a specialized center with the expertise in diagnosing and managing the invasive placentation. And delivery should be in a specialist center with logistic support for immediate access to the blood products, adult ICU, neonatal ICU, and handled by a complex pelvic surgeon team. Now, elective delivery of these women should be managed as spoken by a multidisciplinary team. And in an emergency, you should call the more senior clinicians available for help. A single course of antenatal corticosteroids is recommended between 34 to 36 weeks for pregnant women with a low lying or a previa, and is appropriate prior to 34 weeks in women at a high risk of preterm birth. So these you should always be ready. You should have given them antenatal corticosteroids, because these patients most can sort of bleed anytime, and you might have to do emergency surgeries preterm. So what should be planned for, when should delivery be planned for these women? Normally between 35 to 37 weeks. This provides the best balance between the fetal maturity and the risk of unscheduled delivery. What should be included in consent form? It should be very, very exhaustive. You should explain to these cases that they should, a woman giving consent for cesarean should understand the risks associated with cesarean in general and the specific risks of PAS in terms of massive obstetric hemorrhage, increased risk of lower urinary tract damage, the need for blood transfusion, and the risk of hysterectomy. So you should always talk to these cases and to the family, to the couple, and you should also take the consent for a hysterectomy. So because if it is a placenta accreta, you have to go in for a cesarean hysterectomy. So the additional possible interventions in case should also be discussed, and if you have an interventional radiology, you should also talk about that. Anesthesia, which one should be given? Though the choice for anesthetic technique for cesarean in these women has to be made by the anesthetist who is available, or who is what is his or her forte, whether they would prefer a general anesthesia or a regional anesthesia. The woman should, it can be definitely done under regional anesthesia, but it could be converted to general anesthesia if needed. So what surgical approach on uterus should be used in these women? One should consider vertical scar and or uterine vertical incision when the fetus is in a transverse lie to avoid the placenta, particularly if it is below 28 weeks. Consider using pre-op or intra-op sonography to precisely determine where the placenta is located, so as to you can optimally plan the uterine incision. And if the placenta is transected during the incision, immediately clamp the umbilical cord after fetal delivery to avoid the excessive fetal blood loss. Cesarean hysterectomy with the placenta left in situ is preferable to attempting to separate it from the uterine wall, And when the extent of accreta is limited in depth and surface, and the entire placental implantation area is accessible and visualized, that is completely anterior, fundal, or posterior without deep invasion, uterus preserving surgery may be appropriate, including partial myometrial resection. So you have to decide whether you would go in for a complete hysterectomy, or if it is just localized, then you might have to do a partial myometrial resection and uterine repair. So there are various techniques of doing hysterectomy, and there are chances of urological injuries or injuries to the bladder, to the ureter, 80% chance of injuring the bladder, and 17% chances of involving these cases that we can injure the ureters. So some cases, some people suggest that you can sort of preoperatively you put in ureteric stents, and do also a cystoscopic assessment prior, so as to evaluate the involvement of the bladder. Now, some authors suggest that deliberate cystostomy, or some say identify the percreta, villus tissue, and excise the involved bladder rather than doing the difficult dissection. So, but there are currently insufficient data to recommend routine use of ureteric stents in cases of PAS, and these may have a role when the bladder is invaded by the placental tissue. So methods to prevent bladder and the ureteric injury is that you open the retroperitoneal space, visualize the ureters. One major factor to avoid urinary tract injury is to avoid major intra-bleeding, because if you have massive bleeding, then your visibility is limited, and your dissection becomes poor. So you have to first do a proper dissection, visualize the ureter, and then start your cesarean. Or you can fill the bladder before the surgical procedure, so that you can, this allows for an easy cystostomy when needed, and also a better dissection of cervix when you are doing the total hysterectomy. Uterine preserving surgery, uterine preservation versus expectant management. So uterine preserving technique should only be attempted by surgeons who have enough expertise to manage such cases, after a proper counseling regarding the risk of uterine preserving technique, and with a proper informed consent. Because sometimes you might have to later on, if she bleeds, then she might need another surgery, or then that in that particular surgery you might have to do a hysterectomy. So there is limited evidence to support the uterine preserving surgery in placenta percreta, and women should be informed of the high risk of peripartum and secondary complications, including the need for a secondary hysterectomy. So methotrexate in such cases should not be used for expectant management, because it is of unproven benefit and has significant adverse effects. Leaving the placenta in situ, or what you call as the expectant management. So expectant management, elective peripartum hysterectomy may be unacceptable to women desiring the uterine preservation, and in such cases leaving the placenta should be considered. And when the placenta is left in situ, arrangements need to be made to ensure regular review, ultrasound examination, and access to emergency care should the woman experience complications like a bleeding or infections. So when is interventional radiology indicated? Large studies are still needed to determine the safety and efficacy of interventional radiology before you can put it into your routine management of PAS, and women with PAS who decline donor blood transfusion should be cared for in a unit with an interventional radiology service. So the ACOG December 2018, what all are the considerations for a proper optimization of a case of PAS? Pre-op, maximize the pre-op hemoglobin values, verification of the specific timing of planned delivery, identification of exact location of delivery, which place you are going to which particular hospital you are going to deliver her, verification that necessary pre-op consultations have occurred, and you have sort of literally sort of done a lot of counseling with the whole family about the what you're going to encounter, what how much they should be prepared with the blood, the and also the need for a cesarean hysterectomy. Consideration of patient family needs given temporary relocation to PAS Center of Excellence. So if the patient is from very far off, maybe she might have to shift somewhere nearer where if she has this sort of a PAS problem. Intraoperative verification of appropriate complement of surgical expertise, availability of resources to optimize each case, have adequate surgical trays, necessary urologic equipment, verification of availability of related services like interventional radiology if needed, coordination of blood bank with scheduling or timing of the case, post-operative assurance that critical care services are engaged and available. So you have to be prepared pre-op, intra-op, post-operative, and stepwise surgical approach. You have to combine early IV uterotonics just before delivery, transverse high uterine incision at the upper border of placenta without cutting through the placenta, do fetal delivery, exteriorize the uterus and compress against the symphysis pubis by the assistant so that there is transient bilateral kink of the uterine arteries, bilateral anterior division of internal artery ligations, placental extraction, delayed after pelvic devascularization, proper identification of the lower segment by index and ring fingers after identifying the internal cervical loss, repair of the incision. So this is the various different approaches of dealing with these cases. So you should always in such cases where you have a history of any surgery on the uterus, maybe myomectomy, DNCs, a history of MRP in the previous deliveries, or if it is previous multiple cesarean section, always do a proper ultrasound. Think always of placenta accreta syndrome. Be always readily prepared. Call for help. Never hesitate to call your seniors, call your colleagues, and if you are caught up in unprepared without any preparation, maybe. So call for help. Wait for don't fiddle with the placenta. Remove the baby and then don't try to pull the placenta. And prepare your staff, prepare your anesthetist. Let him also get more helping hands. You also call for your seniors, and then accordingly deal with the case. And hopefully the everything can be controlled, but you should always have this emergency plan. And these cases are increasing, so we should always know about how to deal with them. So thank you so much. Now I think we can take questions.
Right, ma'am. Thank you. Thank you so much for such an insightful session. Now, let me see if there are any questions from the audience. I think you have covered almost everything.
Yeah,
Still,
right. Yes.
Yeah. Yeah. Ma'am, the first question is based on your experience. What are the most common challenges clinicians face in diagnosing PS early, and how can we bridge the gap between imaging findings and the intraoperative reality?
Yeah, that is a wonderful question actually. And the whole talk was about this only, because how we diagnose early placenta accreta. That was in a very, very early pregnancy also. If you have a sac much lower down in the uterine cavity, or if it is going into the cesarean scar, definitely these cases are going to go into placenta accreta sort of a spectrum. And in fact, these cases should be advised to going for a termination rather than continuing the pregnancy. So termination, if you are suspecting such sort of a very low down sac, you should and with a previous cesarean section. So doing a termination at that particular stage is much better for the patient rather than her proceeding to placenta accreta and then going ahead with a cesarean hysterectomy. So mostly such cases, if you have, sometimes if it is morbidly adherent, if it is not that badly adherent, you can sort of slice off the placenta, see how it is bleeding, whether if there is active, if it is active bleeding, you can use some maybe you can do a press onto that, you can use a balloon tamponade once or twice. In cases like IVF pregnancies where it is not that badly adherent, but it is not coming off very easily. So we have tried using a tamponade there and remove the tamponade next day morning. But definitely, if you know that if it is a badly adherent placenta, you should always talk to these patients. In fact, if I'm dealing with a case of previous one cesarean only, also I give them a some idea about a morbidly adherent placenta and what sometimes that they may need a blood, they may sometimes land up into a cesarean hysterectomy. So you have to be ready with everything. When you are ready, actually, then you can, the patient also is mentally and the relatives also understand what is going on, that it is not a routine cesarean, it is a high risk case. So they also understand the maybe the leverage of the case that way.
Right, ma'am. Thank you so much for explaining it so well. The next question is, ma'am, what are the key considerations for postpartum management in PAS patient, and what are the long-term reproductive health implications for women who have undergone surgical treatment?
Yeah. So see, if she has undergone, if we have left in some bit of the placental tissue, if we could not remove the completely, it did not come, it was maladherent, and it could not come completely, she might come later on get into secondary PPH. She might come maybe week, 10 days later and have a with a heavy bleeding postpartum. So, or there could be infection. So, these are the two things we should always look for, and we should tell these patients on discharge that any foul smelling discharge, any history of fever, uterine tenderness, or maybe rigors and chills. So, these are the signs of infection. So, they should report back to us. And if there's heavy bleeding, also they should report to the casualty or the labor room whenever they encounter such sort of a situation. So these are the two things: infections and bleedings. And these are the health issues. And later on, in the second, as I had in my first slide, in the second or third slide, also I told that worst, I mean, the best, if she had a previous history of placenta accreta, you have a very high chance that it is going to repeat again. So we one should be very careful. If she had accreta just this time, we should be very very careful for the next time, and maybe the next time she would land up with a hysterectomy that way.
Right, ma'am. One last question for today. That is, while international guidelines provide a structured approach to PAS, do you feel there are areas where real case clinical practice diverges, especially in resource limited settings? And how can these challenges be addressed?
Yeah, see, we this is very important and very nice suggestion and a question as well, because in our limited resource settings these days, first and foremost thing is that we should avoid doing unnecessary cesareans. So if we avoid doing that, we can avoid such sort of catastrophes that follow such unindicated cesareans. So that is why, in fact, these days it is of prime importance that we as obstetricians look into our cases very with a lot of all these complications that we may encounter later on. Doing a cesarean for a primary, we can easily say, okay, she did not progress, but have we given her enough trial? And if for a mild thin meconium we are doing a cesarean, so all these things, if every obstetrician limits their cesareans, these complications will become much lesser. So one thing, the basic thing in our resource settings we should be doing is to limit the number of cesareans, unnecessary cesareans or unindicated cesareans. And definitely, if you have diagnosed, you should not deal with them. You should refer these cases to higher center where they can be dealt with, because the amount of hemorrhage that you encounter, massive hemorrhage in such cases, it is unbelievable. So you should only deal with whatever your sort of setup allows you to do. You should not become heroic, because every life matters. And if you refer her to a case which has all these facilities, that is the best thing that you can do to your patient. So if you have a limited resources, you should not even dare to touch. You should refer these cases.
Right, ma'am. Very, very practical approach, I would say. And with that, we come to an end to this Q&A session. So, ma'am, before wrapping up, I would like to thank you for your such an insightful session and for sharing your valuable perspective on such a very important topic. And of course, thanks to all our attendees for their active participation and thoughtful questions. So, ma'am, thank you once again for putting up all your effort and time. Thank you. With
Thank you
this, we
so
are
much.
concluding here.
Thank you, Arpita, and thank you, Team IJCP, and thank you, Dr. KK sir. Uh, we remember you always. You're always there as our teacher guide, and thank you each one whoever has joined today. I hope this talk was useful to you, and I'm sure we'll get another good topics and see you on the same platform sometime again. Thank you.
Yes,
Bye
yes,
bye.
ma'am. Surely. Thank you.
Bye.
Thank you, ma'am.
Okay. Bye bye.
Bye, ma'am.